are there cases, obviously a loaded question, are there cases where a patient still may have radial pulses, but it would be prudent to hit them with IV epinephrine, categorize them as shock, even though they still have some maybe weak, thready radial pulse, right?
So here, you're going to take the time to start an IV, and in that situation, if you can capture them at that moment where your MAP is probably over 65 and your diastolic has to be over 80, if you have a radial pulse, 80, 70, 60, right? So my whiskeys are great at that, you know. So you got somebody who's still got a radial pulse. They're going to accept that intermuscular injection, and it should work. So, but what you're saying is important. So recognize you do have a radial pulse, and that needs to stay as your trigger point, okay? You give the IM dose, you start the IV, and you keep feeling for that radial pulse because, yes, when you hear the stridor, when you see the retractions, when you see the increased respiratory rate, recognizing that this person probably has a huge lactic acid already because cellularly they're in shock, right, you should be ready and willing to give the intravenous epi. So I don't know if I answered that, but I'm saying that you must be prepared to do both.
And likewise, to your point, there's no harm in popping a couple caps off and having it tape it to their forehead so you know where it's at, right?
And don't be afraid of redosing. I mean, just like we talked before about albuterol, and you might not have wheezing until I've given 3, and all of a sudden I have wheezing. Keep going. You're doing something that's making it better with the epi. Even you redose. If you don't see change, it's probably because they need more, just like in your case.
The people that die from anaphylaxis, I'll say it again because I know I just recently said it. They die from lack of epinephrine.
What does Dr. Singer say? They die from hypoepinephrinemia?
That's good.
Did he say that?
I think that's his line.
I love that.
Or something to that effect. It's very close. That's off to Jordan. That's
good.
Yeah, that was his bullet point when we were raising that maximum for push dose epi at 50 mics. He's like, I don't care. He's like, what they're going to die from is, not 20 mics. They're going to die because they didn't get enough, right? Sure. And that is, there's a lot of simplistic truth to that, right? Is if I'm concerned about 10 or 100, right? And the patient really is sick enough, you need to choose the higher, right? It's
100%.
Yeah.
And I think to kind of like twist Caleb's point and yours a little bit too, and to follow up on what Dr. Spanner said is that might be that patient that received the epinephrine pen, right? And maybe they have one at home, or somebody gave them one. They're not getting better, right? So why would I just immediately repeat that? That didn't work. So I think sometimes we get hung up on that. Well, they were given an epinephrine pen. It's okay. We can give more. That's not being effective. So I need to change our tactic.
Yes.
So I think that's some of the things we see out in the field. In schools now, they have the AEDs, they have the epi-pen, anaphylaxis kits, and they're just becoming more common as they're available in high populated cities and stuff.
And not to stay on anaphylaxis forever, but I think it's important to remember what anaphylaxis is as opposed to a bad reaction. Is it multi-systems or not?
Correct.
And then at what point did they already receive that EpiPen, and were they trained to know when to use it and how to use it? And you might not see what you want to see because maybe it's expired. True. But just knowing the difference between multi-systems and not is important. It's when is it anaphylaxis?
Yeah, no, I think that's a good point. Like, I think people get hung up on...
I have urticaria, so it's anaphylaxis.
Yeah,
do you have that and respiratory problems? Do you have that and gastrointestinal
GI problems?
Other systems are affected. And no, to your point, you make a good point about the EpiPens being expired.
They're expensive, right?
That reverts back to taking our time to do our history, look at the patient. And I know this is more of an aggressive or chaotic scene usually with a bad anaphylactic patient, but is that epinephrine pen expired?
Was it used properly? I can recall a case. I don't know if we've talked about it before. Years ago, I went on a lady who gave her son EpiPen, but she had it backwards. So when I got there, it was stuck in her thumb, and she couldn't get it out. So we had to take her, but then also
that's
her
an
son
end vessel. That's how you lose fingers.
Yeah.
So this, but then obviously the son who needed it didn't get it, so we had to deal with that as well. So training, and is it theirs? Is it somebody else's they're giving to Scott.
I mean, EpiPens are expensive, and that's kind of where I was going, I guess, with my point. I agree with yours as well. It's, those are expensive. So maybe financially someone was not able to replace that. So they held on to an expired one that might be less effective. But, also it wears off. Medication wears off. So
Epi wears off quick.
On the converse of that, to that point, right? Let's talk about the person. We've talked about the initial resuscitation. So let's say we do use that 100 mics of cardiac epi, 1 milliliter of cardiac epi, and we get a positive response, and we get our Benadryl, and we get our fluids running, and we get our steroid of choice in this area. It's methylpred. And then during transport, right, their blood pressure starts sagging again, right? And let's say we've already maximized our fluid resuscitation through some of the things we talked about a minute ago, and this patient is now very amenable to push dose epi, right? So you can go back to the full gun, right?
It's tough.
Yep.
I mean, if you have the Benadryl on board, you've already controlled at least histamine release. It's not actually an antihistamine. It's actually a mast cell stabilizer so that you prevent more histamine effects. That's actually why it's kind of a misnomer. I don't know why that always bugged me. But, the steroids aren't going to do a damn thing for like
during
an hour,
right?
30 minutes to 60 minutes.
In this case, their blood pressure, right,
but it's
starting to get soft, right?
I would say that if it's starting to get soft and you're on top of it, push dose epi is fine. It may not be enough.
If they crump.
You need to be prepared to go back.
Back to the cardiac.
And I think, don't get caught up on that. Call med control. This is what I've done, doc. This is what I foresee. I still have 15 minutes to you or something. What do you suggest? I mean, let me run it by you. So I just don't be afraid to call med control, I guess.
That's fine. Caleb, I just want to make sure that while you're doing that, you realize that's still your patient. And, calling med control, we're there for you, but you're also the person who's going to make that difference. And in anaphylaxis, that means treating them before you call med control.
If they're
that goes back to Jordan's hypoepinephremia, right?
It's scary.
I mean, if they're crashing, obviously, but if you have somebody who's teetering that line of are they starting to dip again, and I got a minute, let me call and ask you, and maybe you have something better that you might suggest.
No, I agree.
It's going to be push dose. It's just.
I agree.
Let's turn a little bit and go back, if you don't mind, to our obstructive shock, and you had started down the path of your soldier who needled the sergeant and saved his life. And we had one of our medic students, he darted somebody. It was a very similar case. It was an MV. Didn't he dart him 4, 5, 6 times? Going to the trauma center, jumped on with another agency, and
I feel like that's right. I had a medic student ride with me out here, and we darted somebody's voice.
That was bilateral, that motorcycle accident. But
let's go to finger thoracotomies.
We're not there yet. We have to have a whole thing on that. But I want to point out the discrepancy from what is taught, and again, we're getting better about it in paramedic school, but let's think back to when we went to
could
paramedic
you imagine
school.
15 years ago, putting more than one needle, if maybe any needles in somebody?
But beside that aside, right? I mean, we were taught an exhaustive list of things that could be signs and symptoms for tension pneumothorax.
Oh, tracheal deviation. How soon does that happen?
I can picture that box
with the trachea tethered to your manubrium. Pretty unlikely, although it's very common on the X-ray with a tension, and God forbid you should not be getting that X-ray.
You shouldn't see it.
We should have fixed it.
Already fix it. But you've distilled that down certainly in your teachings to us, right? Is basically. Look for 3 things, right? Look for the absence of lung sounds on the affected side. Give me a good story, and again, keep it simple. No radial pulses, right?
Done.
Those are your teachings to us, just to simplify it. And it's funny when I regurgitate that to other providers. They're like, "Oh man, I was taught this big list of stuff in paramedic school." It's like, yeah, but a lot of that is tough, if not irrelevant, pre-hospitally. Those
I think if
three simple things.
you focus on what really is pushing your care.
Right.
You need to distill things down. If you don't simplify them in a chaotic environment, you're going to miss the forest for the trees.
Yeah. Cognitive overload.
Right.
Right. Yeah, you're going to be drowning in so much
cognitive overload. That's the perfect analogy, perfect way to describe that.
Yeah.
They're going to be symptomatic. I think you have a story of yourself going through a pneumo, right?
It was simple pneumothorax,
Simple
right?
pneumo,
Yeah.
but you still felt discomfort. You still felt short of breath, I'm sure.
It's it hurt. It hurt to breathe, right?
Yeah.
In my case, I was a simple pneumothorax, right? Tall, thin, skinny males, specifically runners.
I know. I have the same problem.
Yeah, I know. I can tell.
100 kilograms.
You're all 100 kilos of Dr. Spanner, I ruptured a blood and subsequently started with a 20% pneumothorax, and looking back at my experience in the emergency room, it was a fairly long time, and they vacillated a long time on whether they were even going to do any type of thoracic decompression.
They put a pigtail in? Or?
They eventually did,
Okay.
right? But it was a very long time because I was 20%, and yeah, it hurt to breathe, right? But the whole time I had a fine blood pressure I was making. So was it terribly uncomfortable? Did I have diminished lung sounds? Yeah.
It was also not traumatic.
I was also, the story wasn't there, right?
Right.
So, I can use that as some teaching points to, I'm glad you brought that up. But, that's why Scott wasn't emergently decompressed when he went into the emergency room.
Right.
I walked in, I had a pressure, I didn't have a story. Right, it was a simple, and then eventually I expanded some more. I did get, I did eventually get one of three, three chest tubes, but and eventually required some surgical intervention. Right, but nevertheless, I was never a tension because I always maintained my pressure. That pressure never built up.
Right.
I never lost my radial pulses. I never I never squished my vena cava, and I always had good venous return, thus good cardiac output, right? Why I never got popped here. I eventually got a couple here. I got some chicks dig the scars on the side.
That's nothing.
Do you want to see my flank?
Check out my flank scars, baby.
We'll be editing that out.
Oh no, that's gold.
Do the outtakes.
That's a leave-in right there. But
I think to your point, it was kind of like it was taboo. We want you to recognize it off this long list, and I think you hit all the nails on the head there because it almost seemed like they didn't want us to treat it. Now, fast forward 15 years,
Want
10,
us
15
or
years.
trust us at that point?
Probably both. And now it's. We're very proactive on that. If they're symptomatic, simple checklist. And then let's go to the flip side here, since we want to talk about shock, and we'll take Dr. Garlisi's road here, which goes down a bad path for a trauma arrest. We should be pulling the trigger on bilateral needle decompressions as a protocol rule out, and that's the importance of it. And it's a simplistic procedure that we should be able to rapidly identify, rapidly treat, not only mid-clavicular, but also, mid-axillary.
yeah,
Especially we get into, like, when we had Joe Sugar on, we talked about,
Vests.
we talk about, if they're wearing any type of vest, plate carrier in the RTF setting and TEMS medic setting, you definitely want to be going to the mid-axillary.
it's a temporizing procedure only, though, right?
Yes.
Ultimately, in our area, right, the doctor needs to, do it, put a chest tube in or finger thoracostomy, whatever they're going to do, at the destination. You baited us earlier, right?
Oh, he led you to it.
Yeah, the finger thoracostomy we're done in some other services elsewhere in the States currently is prohibited the way our scope in Ohio is written. But we know that there is a path that is coming that'll allow us to expand on some of that stuff and do some of these other procedures that that we've touched on, even in this even in this particular program. So, but I just wanted to go back and make sure that your teaching. I've always embraced that, right? Those three simple things, because again, I was taught an exhaustive list of things that was like, how practical is it for me to remember this crap? It's crap. Right. Look for these three things. Boom. And then again, back to it all comes down to, tell me the story.
Well, yeah, that's what I was going to say. But it all comes down to just doing what's best for your patient.
Right.
I mean, there's a reason in active shooter situations you're given chest seals and needles, basically, and tourniquets. Yeah. That's how you're going to save them first. Correct. So,
100%.
And what's going to happen if you don't do it and they needed it versus what's going to happen if you did do it and they didn't need it. I mean, it kind of outweighs what could have happened if they did.
Significantly.
So I just think it's one of those, if you pick up on some of these signs, if you think for any reason the mechanism was there, the story lines up, err on the side of caution and then let the docs deal with it later.
Yeah.
And if we
better than just not doing anything,
because
not giving them the epinephrine and profound anaphylactic shock, not needling them when they're sitting there showing you an obstructive event,
not because fluid volume, when they're depleted. I mean, it all comes down to just doing what's best for the patient.
And you don't want to be that one person who says they were alive when we pulled up. You may be the one who says they were in trouble. This is what I did.
Action is always defendable.
Yeah.
Action is always defendable. But
you don't want to be the one that missed the boat where you went from aerobic metabolism to anaerobic metabolism and everything's going downhill and you're not paying attention to the end title. We know the end result there.
Scott, I'm sorry to interrupt, but Scott used to have this poster in his office.
It's in my new office too.
Is it?
Yep.
What's it say?
It says, patients don't suddenly deteriorate, healthcare providers suddenly notice.
That's pretty good.
Just what you were saying.
Yeah.
That is a very succinct way of, pull your head out of your ass, right?
100%.
But I printed that. I thought that to be, very appropriate, and I had that over my shoulder. And, again, when I was counseling a lot of providers, it was, folks, this is where we're at right here, right? Is this patient didn't die as you pulled into the emergency department. This patient had been dying since you...
And you missed it.
Yeah, we missed a boat on it, right?
Yeah.
And you usually have multiple red flags telling you things. We just have to listen to them. That little voice on your shoulder is telling you something's wrong.
Right.
And you got to listen.
And be willing to listen. I think certainly in busy services where you can have a lot of routine, right? And then you get caught in the complacency trap, right? I've seen this 100 times and it was nothing. Well,
one out of 100.
This other time. Well, let me tell you a story, right? This other time is the one that ultimately
gonna bite you.
It's gonna bite you.
Yeah. Complacency kills.
So we've talked about the neurogenic, we've talked about anaphylactic, we've talked about septic, and we've talked about some of our distributives. Let's talk about cardiogenic.
Okay.
So this is actually one of my favorites because it's.
I mean, cardiogenic is just not muscle failure, and I think people get that kind of tied into them. They're like, cardiogenic shock, they must have heart failure history.
There's no squeeze, yeah.
Right, there's just not a squeeze. It could also be arrhythmic. So, knowing what you're dealing with or knowing what the origin is. I mean, for example, let's say cardiogenic shock in a hyperkalemic dialysis patient. So you have peak T waves and a widening QRS, realizing that this person's defibrillatory threshold is so high that they can't get calcium down their calcium channel to get the myocardium to squeeze. In what you're staring at here is actually cardiogenic shock due to a heart muscle that simply can't contract. Recognizing that this cardiogenic shock needs you to be aggressive with the only medicine that helps in hyperkalemic events like this, which is, of course, your calcium.
Yeah.
And if you don't get that calcium on board immediately,
See sine wave.
you're going to see a sine wave, you know, and then you're stuck.
Like any bad medic will tell you, if you don't know it's on the monitor, just wait a minute.
Right. And it doesn't even take a minute. I mean, those things progress pretty rapidly. If you want to see a nurse in my department, like, know what's going through my head, because I work in an area that has a fairly large amount of dialysis patients.
Right.
And they just have to miss a few sessions because it's a chronic disease, and nobody likes a chronic disease, and every now and then you throw your arms up. I've seen sine waves, I've seen T waves that are off the EKG, you know, and I'll grab a nurse and I'm like, you have 3 minutes to get me calcium chloride in here now. And they know it's serious business time. And of course, the sine wave for our pre-hospital providers is what pulls the trigger for sodium bicarb, but that individual needs to get another line on a dialysis patient because you don't mix those two.
Another IO.
Right, or an IO. That's just the point I was going to make. You know, get that albuterol and keep that albuterol going. You know, all we're doing with albuterol is hiding the potassium by kicking up the sodium-potassium pump. All we're doing with bicarb is raising the pH to exchange hydrogen and potassium and get potassium into the cell. It's only the calcium that pushes down the calcium channel and stabilizes that membrane. But that's just one episode of cardiogenic shock. Certainly young people, and I've seen this more than too many times, who have bizarre viruses.
Yep.
Coxsackie virus, I had it in a 19-year-old who came in with a heart rate of 140 and a pressure in the 70s. I ended up sending him down. He was on ECMO for 9 days.
Wow.
And he lived. I mean, he survived. But my goodness, what were we doing? We were pressing him, even though, you know, he has a weak muscle. And if you press a weak muscle, the afterload is so high that it could actually not help and be detrimental. But again, you can't leave them in shock.
Right.
So myocarditis is another form of cardiogenic shock. And certainly heart failure with poor ejection fraction can tip that border, and the next thing you know, they're in cardiogenic shock because of true pump failure. But you got to look at the rhythm. You got to get the history, like Caleb was saying before. Give me a history. If you get me a history, did they have an MI? If they had a significant MI where they have more than 40% of the left ventricle that's akinetic because they're not providing perfusion to that area of the muscle, so that area of the muscle is not producing ATP, and you have an akinetic area. If it's over 40% of the left ventricle, they're in heart failure. We're going to press that patient too. What they really need is to be, you know, recannulated and have that thrombus removed from the area that's akinetic. So the reality of it is that cardiogenic shock is truly a shock that could be a heart attack, an arrhythmia, a muscle weakness. It could be due to profound electrolyte abnormalities. But something's not letting the heart function. And when it loses its contractility and you go into shock, you've got to give them the proper dosing medication, like push-dose epi, to get that muscle to move, even in its weakened state. And that's tough. It's not as hard, especially guys like Dr. Hill, who, you know, was trained on ultrasound. I had to pick it up from my residents, and they've been very helpful. But you can put your ultrasound right on the person's chest, and you can see if that heart's just pounding like it should, and they're in shock for another reason. Or you can see if it's really losing the proper amount of ejection fraction, the proper amount of kinesis, and that person is in heart failure or pump failure, and that means cardiogenic shock.
We're taught in ACLS, our tachyarrhythmia algorithm,
Right.
our bradyarrhythmia algorithm, and what we're really teaching you are the ends those are 2 cardiogenic shock, right?
Yeah,
We're
complete
stating
heart
that.
block.
It's a rate mediated,
Right.
It's a rate mediated cardiogenic shock, but the pump's failing because you're either too fast or too slow, right? And that's how we break it down in
Excellent.
class, right? Is we call it what you're really treating is a rate mediated, cardiogenic shock, right? And if you leave them go long enough, then you see those classic signs and symptoms of cardiogenic shock, right? But we're in a good place here with with push dose epi, and if your medical director allows, there's even ability to drip that baked into the protocol. There's some docs that still want their departments to do that, so there's it's slid in the back if the doc wants you to do that, but. Our entry, I don't know if I said it on here before or not, but you and I have certainly spoken. This day and age, there is really few excuses to roll into an ER with a hypotensive patient.
Absolutely, 100%.
Right? Gone are the days I started the fluid bolus, it just hasn't brought the pressure up yet, right? We don't get to throw our arms up anymore and be like, well, I did what I could, right? Because we can go that extra step, but it's not this big leap. It's just this little extra thing, right?
100%.
Right? To keep these patients perfused.
We have too much in our bag that we can't respond and get somebody out of shock. Every minute they're in shock is just like a minute of stroke, a minute of heart attack. All these things that we focus on, like we said at the beginning.
I'm glad you started with that. That's great.
Of this podcast is remembering that every minute you leave someone in shock, cells are dying, tissues are dying, multi-organ failure is kicking in, and that mortality rate is algorithmically climbing.
All right, what else do we need to cover?
That was a great outro.
I thought that was great. Yeah.
I think we hit a lot, and I think that we made a lot of that really relevant, hopefully relevant to the provider, right? Make it actionable to actual EMS care and thought processes that.
Be aggressive.
Yeah.
Be aggressive.
Hold on, we got some pom-poms around here for you.
You guys do make this easy.
Well, this is fun, right? I mean,
But you panicked me because you acted like you had not prepared,
Well, I didn't
we hadn't prepared a bit.
That was really
I
good.
didn't prepare. I wasn't lying to you.
Oh, you weren't lying?
I actually really
I
enjoyed
take these
this
off?
lecture.
Sure.
Oh, good.
Oh,
We're done, man. Oh, my ears are killing
I know
me.
they're sweaty.
all right. Don's got to get the headset off. Dr.
No, I
Spanner's
mean,
got to
look
get
at
the
the size of these ears.
Dr. Spanner's got to get the headset.
Look at the size of these ears. I mean, they've been squished for hours, and I'm like, oh my god! Like about 15 minutes ago,
You can hear the mice out in the bays.
My ears were like pounding. I'm like, oh my god! Please let me take these off my ears.
All right, everybody. Well,
So next time I come, bigger ear.
we'll see what we can do.
We can do.
All right. Thanks everybody for tuning in. And don't,
we're still on?
Yeah, well, I got to do an outro here.
Oh, I'm sorry.
Thanks everybody for tuning in. Don't forget this. All the show notes on the prehospitalparadigm.com on our website. All the links to the video product and the audio product as well. You'll find all that there, plus a bunch more. Like us on Facebook, follow us on YouTube. We appreciate you tuning in, and we'll see you next time.